Good morning, everyone, and welcome to the October board meeting of Access Health. I understand that our vice chair, Paul Philpott, may not be with us, but it's great to have the team we have here. Let me start by having the board members introduce themselves. So this is Charlie Klippel, Chair.
Ted Doolittle, State Office of the Healthcare Advocate.
Cece Woods, longtime board member.
Grant Ritter, board member.
Matthew Brockman.
Morning, Claudio Gualtieri from OPM.
Paul Lombardo from the Insurance Department.
Deidre Gifford, Department of Social Services.
Morning, Nick Venditto from the Department of Social Services.
Terrific. I think that's everyone. Thanks very much.
I believe Mr. Steve Hernandez just joined us.
Oh,
good morning, Steve Hernandez here.
Thank you.
Okay, I just want to make sure that I got everybody. Charles Klippel.
Yes. I
Paul
think I
Philpott.
heard. No.
No. Okay. Cece Woods.
Here.
Thomas McNeil.
Present.
Grant Ritter.
Here.
Steven Hernandez.
Steve here.
Matthew Brockman.
Here.
Commissioner Deidre Gifford from DSS.
Yes, present.
Claudio Gualtieri on behalf of Secretary Jeffrey Beckham from OPM.
Here.
Theodore Doolittle from OHA.
Here.
Caroline Zambetti on behalf of Commissioner Nancy Navarrete from DMS. Paul Lombardo on behalf of Andrew Mays, Connecticut Insurance Department Commissioner.
Here.
And Commissioner Mansi Tutani, Department of Public Health. Thank you.
All right, terrific. And now maybe I could ask the executive team of Access Health to introduce themselves.
Good morning, James Michelle, Chief Executive Officer of Access Health Connecticut.
Good morning, all. Tony Crow, Chief Operating Officer for Access Health Connecticut.
Good morning, all. Darrell Jones, Director of Finance, Access Health Connecticut.
Good morning, all. Susan Richby, Director of Legal and Governmental Affairs, Access Health Connecticut.
Good morning, Caroline Lee Ruette, Director of Marketing, Access Health Connecticut.
Good morning, Glenn Jurgen, Director of Human Resources, Access Health Connecticut.
Good morning, everyone. Tammy Hendricks, Director of Health Equity and Outreach, Access Health Connecticut.
Terrific. Thank you all very much. Anybody we missed? Marson, I understand we have no public comments. Is that correct?
That's correct, Mr. Chair.
Terrific. Then we can move on to the minutes. I would ask if there are any comments to the minutes. And if not, I would ask a motion to approve those minutes.
Motion to approve. This is Grant Ritter.
Thanks, Grant.
I'm McNeil, second.
Thanks, Tom. This is Charlie Klippel, yes.
Okay. Claudio Gualtieri.
Can I abstain? I was not part of most of the meeting last time.
Okay. Deidre Gifford.
Yes.
Grant Ritter.
Yes.
Steven Hernandez.
Yes.
Theodore Doolittle.
Yes.
Cece Woods.
Yes.
Thomas McNeil.
Yes.
And Matthew Brockman.
Yes.
Thank you.
Now we have a couple of committee appointments. So Susan, I will give the floor to you.
Thank you very much. Good morning, everybody. We have a couple of additions to standing board committees and also to some of our advisory committees. And as you may remember, the bylaws of the exchange require that the board approve, appoint, and remove members of standing and ad hoc committees. So we are here before you today with a couple of these admissions, and we're really excited and, grateful for everyone's volunteerism and stepping up to serve on more committees. So first, we have a new member for the Health Equity and Outreach Advisory Committee, the new committee that just met for the first time last month. And I believe this may have come up from a committee member, this recommendation at the meeting last month. We'd like to add Holly Hackett to this committee, and she is a strong community advocate. She works for Keep the Promise Coalition, which is an advocacy group focusing on mental health, substance abuse, disabilities, and other equity issues. And she also has worked on a number of other initiatives around the state on all sorts of advocacy issues, but really focused on equity. So I think she'll be a really terrific addition to this committee. So if we want to do, should we do one at a time, Charlie?
Yeah, let's do that one if
Okay.
that's all right. Just because the others are directors. So if there's any discussion of this appointment, I welcome it now. Otherwise, I welcome
Mr. Chairman,
motion.
do we need a motion, Susan, for this?
Yeah,
Yes.
I think he's asking.
Okay.
I think
I
the
then
chair
would
is
move
asking for
to
discussion and a
appoint
motion.
Holly Hackett as a new member of the Health Equity Outreach and Consumer Experience Advisory Committee.
Thanks, Ted. Second?
I'm
Second.
happy to second the
Gifford.
motion.
All right, I'll let Marson figure that out, but this is Charlie Klippel, yes.
I believe it was Ms. Woods as first.
No, it wasn't.
It,
No.
it was either
It
Commissioner
wasn't.
Gifford or myself, and I defer to,
Okay.
I'm happy to give it to Commissioner Gifford as a second.
Okay, okay, thank you.
Charlie
Okay.
Klippel, yes.
Thank you. Claudia Gualtieri,
Yes.
Dietrich Gifford,
Yes.
Grant Ritter,
Yes.
Steven Hernandez,
Yes.
Tito Doolittle,
Very happy to vote yes.
thank you. CC Woods,
Yes.
Thomas McNeil,
Yes.
and Matthew Brackman.
Yes.
Thank you.
Terrific. Susan, I hope you'll extend our welcome and congratulations to her as she starts on this committee.
We will. Thank you, everybody. And then we also have some proposed additions for some of the standing board committees. And again, we really thank board members for stepping up and their interest in serving on additional committees. So today we'd like to ask that Ted Doolittle be added to the strategy committee and that Matthew Brockman be added to the strategy committee as well as the finance committee.
Terrific. That's great. And thank you all for, let me echo Susan's thanks for participating in these committees. Unless there's any discussion, I would ask for a nomination for those two appointments, or three, I guess.
So moved, Mr. Chair. This is
Thank
Steve.
you. Second?
Seconded. This is Grant Ritter.
Thanks, Grant. All right, this is Charlie Klippel. Yeah, and we're voting on both appointments to three committees here. Charlie Klippel, yes.
Thank you. Claudia Gualtieri,
Enthusiastic, yes, especially for welcoming Matt Brockman, who was the brainchild of a lot of framing up of those budget hearings and workshops that we've been doing. So welcome, Matt. I look forward to working with you on that subcommittee.
Dietrich Gifford,
Yes.
Grant Ritter,
Yes.
Steven Hernandez,
Enthusiastic, yes. Same reasons for strategy for Matt and Ted.
Tito Doolittle,
Yes.
CC Woods,
Yes.
Thomas McNeil,
Yes.
and Matthew Brackman.
Yes.
Thank you.
Uh-oh. No, thank you guys very much for the participation. You will make valuable contributions as you have already to the board. With that, James, I give the floor to you.
Thank you, Mr. Chairman. Good morning, all. I'm James Michelle, the CEO of Access Health Connecticut. Welcome to our board October board meeting. Thank you so much for joining us today. Before we get started, I wanted to update you on several items. First, I would like to introduce Rebecca McClare. She's our new Director of Technology Operations and Data Analytics. This is the role Rob Lundo held before he left. Rebecca has been with Access Health for 9 years, working very closely with Rob for the last 5+ years. She is the most ready and capable to take over for Rob, and we are very fortunate to have her in position also as a new member of the SLT. I think I forwarded to the board Rebecca's background last month. So I welcome Rebecca to the team, and you'll be hearing from her in the near future. Secondly, we are working hard to prepare for the unwinding of the public health emergency. We are updating our systems and working closely with the Department of Social Services, the Center for Medicare and Medicaid Services, community organizations, and federal health qualified health centers, as well as other places Connecticut residents go to for help. We will continue to keep you up to date on our progress, and Susan Richby will give you a more detailed update on our preparation. Last month, Susan updated the board on our SMART audit. This is an annual review of our systems that we do every year. We send it to CMS. We've heard back from CMS. I'm happy to report that it was a successful audit with no recommendations and no follow-ups needed based on CMS's response to the SMART audit. In addition to that, every year before open enrollment, we have to do an open enrollment readiness review, which is conducted by CMS. We completed that audit mid last month, and CMS has gotten back to us and they've indicated that it was very successful as well. So I want to extend my deepest appreciation to our team for getting us ready for open enrollment, as well as meeting all the requirements of the SMART audits. And finally, we have held 2 board budget training sessions, one on revenues and the other on expenses. We have 2 more coming over the next 2 months. Regarding our meeting today, we will begin with news about open enrollment, which begins on November 1st through January 15th. Last week, we hosted 4 regional planning breakfasts in Groton, Hartford, New Haven, and Norwalk, where our team spoke with brokers, certified application counselors, and community partners to answer their questions as we all prepare for our 10th open enrollment. We now have over 400 brokers registered with Access Health for the 10th open enrollment. Today, we will hear an open enrollment technology update from Katie Hearn, new Associate Director for our Enterprise Project Management Organization, a marketing status report from Caroline Lee Ruette, Director of Marketing, and a review of our community outreach strategy from Tammy Hendricks, Director of Health Equity and Outreach. Following that, Julie Andrews, Senior Consulting Actuary with Wakely, will walk us through the consumer impact study on the 2023 premium rates in advance of the open enrollment period. And in conclusion, Susan Richby, Director of Legal and Government Affairs, will go over important information in 2 areas. Number 1, she will brief us on the unwinding of the public health emergency, and also give a legal and policy update on the Affordable Care Act, as she does every month. Thank you for your attention this morning and your continued support. I will pause now for any questions before we move on.
Thank you, James. Not a question, but again, thank you to Daryl and to others for putting together those board trainings. Very helpful. Appreciate it. And with that, let's move on to the open enrollment update, beginning, I think, with Catherine Hearn.
Yes, thank you very much. Good morning. My name is Katie Hearn, and I'm the Associate Director of the Enterprise Management Office at Access Health Connecticut. I'll be presenting the 2023 open enrollment updates today. Our open enrollment period, as you know, is scheduled from November 1st, 2022 to January 15th, 2023. This aligns with the federally facilitated marketplace's open enrollment period. This open enrollment period is also known as OE10. During open enrollment, Connecticut residents will be able to enroll into a health and/or dental plan for the 2023 plan year. Access Health usually gains about 15% of new enrollments during OE and generally retains about 85% of our customers through auto renewals and through active renewals. Our focus this OE will be to help to provide clarity on the impact of 2023 pricing to consumers. There is nearly a 15% premium rate increase that may cause some confusion for consumers with premium tax credits. We'll message that premium tax credits will ensure that no one will pay more than 8.5% of their income toward premiums if they enroll in the second lowest cost silver plan. We'll also promote the continued financial help through the Inflation Reduction Act. This will allow individuals over the 400% federal poverty level to continue to receive premium tax credits this open enrollment. And we'll continue our Covered Connecticut acquisition efforts. This will be our first OE where we can market to all adults. Last open enrollment, Covered Connecticut was only available to parents and caretakers. We'll also focus on our retention and transitioning our existing dental enrollees into one application. So this will be the first time that our standalone dental plans will be offered on the same Access Health platform as our individual health plans. And we are also, of course, preparing for the end of the public health emergency and the unwinding of the Husky extension. This will be discussed in greater detail later by Susan Richby. Next slide, please. Here we have our 5-month open enrollment timeline. Access Health is focused on staff and community partner training. We're focused on consumer open enrollment communications, system updates, and PHE unwind preparations that are underway. We'll start to run our enrollment projection letters tonight, and we will run final renewal notices in November, beginning November 17th. These projection and renewal notices are part of the process that helps us to retain over 80% of our customers through auto renewal. We're working closely with DSS and we're tracking CMS PHE notifications. We're actively planning for the end of the Medicaid extension. And we just wanted to remind you that, as usual, we will be sending out our 1095A forms by January 31st, 2023, so that enrollees may reconcile their APTCs when they file their taxes. Next slide, please. Thank you. We wanted to point out some open enrollment challenges ahead. Each year we have some typical challenges and some unique challenges. So this year, to alleviate the impact of some common open enrollment challenges, we're ensuring that our systems are up to date with the latest policy changes. Members are informed about legislative and enrollment changes, and that we have conducted focus groups to ensure our messages are clear. 2023 plan premium changes will be covered in detail, as James said, by Julie Andrews of Wakely, who will be presenting the customer impact premium analysis later in today's meeting. We have updates to our customer plan selections for OE. We wanted to update you on changes to plans offered for 2023. There is a total of 4 plans that have been discontinued. 1 is an Anthem plan and 3 are Connecticut Benefits Inc. plans. That means that 8,200 individuals with discontinued plans will be required to actively renew into plans for 2023. They will receive a letter requesting that they actively renew, which is part of our retention strategy in coordination with our marketing team. This OE, there are also 2 new Anthem PPO plans. And Connecticut Insurance Company, Inc. has entered the standalone dental market with 2 new plans offered on the Access Health platform. Some unique challenges that we're facing this OE include the changing economy. We know that might be a challenge, but we are relieved that the passage of the Inflation Reduction Act will ensure that Connecticut residents will continue to receive the enhanced premium tax credit through the 2025 plan year. We'll continue to make the premium tax credit benefit to our consumer, we'll continue to market the premium tax credit benefit to our consumers so they are aware that the enhanced subsidy is still available through the exchange. Another reason that this OE will be a little unique is that we are in the midst of transitioning our technical vendor, which has been responsible for our system maintenance and operation. That's our application, eligibility, and enrollment system for the last 10 years to a new vendor. The new vendor will provide secondary support to our systems infrastructure during this OE. And by next OE, the new vendor will be responsible for system maintenance. This is a complex project, but we are closely tracking it through our project management processes. And lastly, as I mentioned, we continue to be in the public health emergency. There are now nearly 390,000 members on extended Medicaid coverage. The Connecticut Department of Social Services has a campaign called Update Us so we can update you. Their campaign webpage also has a link to the Access Health website, which will allow enrollees to report changes to their application to keep their information current. DSS has also been engaging community partners since April to encourage Medicaid recipients to update their contact information in preparation for the end of the PHE. This is very important as it will help to ensure that customers do not experience gaps in health coverage. Also, when Access Health enrollees log into their Access Health accounts, there's a banner on the Access Health screen which reminds consumers to update their contact information, dovetailing with DSS's messaging. Susan Richby will provide more details about that later on today. And finally, I wanted to talk about some technology updates on the next slide, please. I mentioned the new integrated dental shopping experience will allow our consumers to enroll in health plans and dental plans in one application. In addition to that, we are offering a decision support function so that if consumers have pediatric dental, covered Connecticut dental, or limited dental benefits in a qualified health plan, the support function will help them decide whether or not to purchase a standalone dental plan in addition to their existing coverages. We have some updated rules and screens in our system to support the Covered Connecticut program. Again, this is the first OE where adults without dependents may qualify for Covered Connecticut. And we also updated our anonymous browsing tool, which is also known as the Consumer Decision Support Tool, so that consumers can screen for Covered Connecticut eligibility. This is a useful tool for both consumers and for our brokers. We have consolidated our paper mailings, which has been a source of frustration for some of our consumers in the past. About 99% of customers will only receive one envelope with only the most pertinent and collated notice information. In addition to improving the customer experience, this will save us a substantial amount of money in the coming years. We have redesigned our account home services to improve self-service navigation, communications, and verification completion. The account home redesign was funded with American Rescue Plan Act dollars, and we released the redesign in the summer of 22, and we expect it to improve both customer self-service and our Net Promoter Score. Lastly, we have implemented new eligibility rules and updated the application to comply with the final IRS rule to ensure family members are correctly determined for financial assistance. Now, if employer offered coverage is deemed unaffordable for a family, not only unaffordable for the employee, families may be eligible for federal tax credits to purchase coverage through the exchange. And Susan Richby will speak more about that later in the presentation. Thank you for your time, and please let me know if you have any questions.
Thank you, Katie. And there's a lot there, so let's pause and see if there are any questions before we move on. Okay, well, thank you. Oh, sorry. Commissioner Gifford?
Go ahead, James.
I was going to follow up to the question that was asked of us during one of the training sessions, or maybe last month, by Board Member Brockman about the forecasted enrollees for when we do have numbers available. We'll forward them to the board. We are looking somewhere between 108 and 110,000 when it's all said and done. It may be higher than that because of the end of PHE, but PHE doesn't end until after open enrollment ends. So we are forecasting somewhere in the range between 108 and 110.
James, my comment was actually related to that. So what I just wanted to let the board know, and Susan or whoever's talking about the PHE unwinding might mention this, but we are not required to reestablish eligibility for all 300,000+ individuals in Medicaid in the first month after the PHE ends. CMS, unusually for them, is allowing states the option of extending, of doing that redetermination in 12 bites over the course of the year following the end of the PHE. And we have been budgeting for that type of a process all along in partnership with OPM. So after, James, to your point, many of the people coming off of Medicaid, in fact, all of them coming off of Medicaid, will likely not be looking to the exchange during open enrollment, but rather at the time of their redetermination, which will be in 12 chunks, we anticipate over the course of 2023. So they would be eligible for a special enrollment period, I'm assuming, because of the termination of their Medicaid eligibility. And so we may see an unusual year for Access Health next year in terms of large numbers of people coming off of Medicaid and potentially being eligible, we hope, for Covered Connecticut, but for the enhanced premiums as well.
Thank you. No, that's very helpful to know. Matthew Brockman.
No, I appreciate, James, you caught me with my future questions, so I appreciate that. And for that information on the 108 to 110. The other question I had was, can you just describe, because we do, with Covered Connecticut being so broadly available, what is the, as a individual, if I'm finding myself on the Access Health website, does the site take me to say, hey, you may be eligible for this Covered Connecticut? Like, what is that user experience like? Just curious.
Hey, Katie, can you talk a little bit about that? Our system is designed, if you qualify for Covered Connecticut, it would default you to Covered Connecticut automatically. But Katie, can you talk a little bit more about that?
Sure. So, yeah, so when we first rolled it out, we didn't have totally complete Covered Connecticut functionality, but we now do. So in other words, based on your inputs to the application, on the eligibility determination screen, which comes at the end of the application, you will be able to see if you're eligible for Covered Connecticut. And if you don't want to do an application and you just want to get an idea of whether you would be eligible for Covered Connecticut, you can do that too using the Consumer Decision Support tool. So you enter information such as the number of people in your family, your household income and such, and our system will tell you if you would be eligible for Covered Connecticut as well.
Cool, thank you.
Ted Doolittle.
Thank you, Mr. Chairman. Ted Doolittle, Office of the Healthcare Advocate. I had a question. It's either for staff or perhaps Commissioner Gifford. It's great, of course, that CMS is allowing us to divide the group into 12 months. How are we dividing that? Is that done alphabetically, by length of enrollment, or how does a person get into group 1 versus group 6, 7, or 8?
Yeah, it's by the time since their last redetermination. The Access Health staff may have more precise information, but it's not alphabetical and it's not random. It's based on their period of enrollment in some kind of a way, Ted.
Thank you.
Yeah, hey, Ted, we've been working very closely with Dr. Gifford's team to make sure we avoid spikes. Right now, we have some months where there are spikes in redeterminations. So that's part of the process, not the only criteria. So some months right now, just normal without the PHE, we have some certain spikes, especially when we first extended Medicaid. After Obamacare came into law, we were the first state to expand Medicaid. So there's some spikes in those months. So we're going to take this opportunity to smooth it out so we don't have huge spikes every month. Because that creates a lot of operational challenges, not just for us, but for customers as well, and our cost and everybody involved. So we're going to try to manage it so that every month is a little smoother. But that's part of the criteria. Others, there are other criteria as well, but that's probably the biggest driver of how we're going to allocate it over the 12-month period.
So we're going to try to make the 12 groups more or less even in size or smaller at first to kind of ramp up, or what?
Yeah, we're going to try to do that to the extent possible.
Yeah, I believe, Commissioner Gifford, correct me if I'm wrong, I believe it's going to be pretty much the same size each month. So it's divided over the 12 months. I think that was what was decided, but you may know better than I do.
Yeah, Susan, I am not recalling the specific details, so maybe we can get those for the board and present them at the next meeting.
Yep, but I think it's going to follow what Commissioner Gifford has said, sort of a first in, first out, so that it'll go in that manner, but spread out through the 12 months. To James's point, this will really help with the volume of redeterminations and enrollments throughout the year.
Great. Thanks so much, everybody. Appreciate it.
Thank you all. And with that, let's maybe ask Carolyn to pick up the story about the marketing.
Thank you. My name is Caroline Lee Ruette, and I'm the Director of Marketing here at Access Health Connecticut. And really excited to talk to you today about our open enrollment campaign. We started this creative brief back in June. We moved forward with our creative concepts, move those into focus groups before we net out with the concept that's winning. We kind of evolved that based on the focus group feedback, and this is where we net out. So lots of work went into this, and really excited to share that with you today. So over on the right-hand side, you're going to see our print ad in English. We do have these in Spanish and Polish as well, by the way. And after this, we're going to show you some of the TV spots too, so you can get a better idea of the look and the feel and the message. So let's talk about that a little bit. So overall, what our creative brief focused on was it's time to take a fresh look. And there's a reason for that. We've been around now for about 10 years, right? So we're moving out of that awareness phase and into really nurturing relationships with folks across the state, many of whom have a relation with us at this point in time, whether it's current or in the past. They've come and kind of experienced what we have to offer. But it may have been a while ago, and a lot has changed, especially within the last couple of years, right? With the enhanced subsidies and financial help, thanks to the Inflation Reduction Act, as well as the family glitch fix this year, there's still a lot of newness, right? So if folks previously engaged with us and maybe they weren't eligible for financial help because of that family glitch issue, right? We want to make sure that they come back and take a fresh look with us this year. Other great things that we have that kind of back up taking that fresh look include the improved dental enrollment experience, right? Folks can shop, compare, and enroll in dental in the same way that they've come to love us for the shop, compare, and enroll process for health insurance. And we also have a ton of options, right? The longstanding no wrong door situation where folks can come to us and enroll in a quality health plan as well as Husky Health, and now the Covered Connecticut program as well. Again, another change, another great opportunity that came about within the last 2 years. And to signify this fresh look, we've literally given ourselves a fresh look. We're using the full range of our color palette. So orange is now our accent color, but very, very prominent as it usually is. So it's familiar with folks who know who we are, but we are using that full range of our color palette. So you'll see some blue in there as well. Speaking of the full range of our message, it's really important this year, just like last year, since we're following the feds, and we are doing the open enrollment period from November 1st all the way through January 15th, that we let folks know predominantly throughout all of our messaging that they must enroll by December 15th if they want coverage starting January 1st, right? There's still the opportunity to enroll between December 16th and January 15th, but coverage wouldn't start until February 1st. And so we really want to make sure folks don't fall into a situation where they don't have coverage for the month of January. We also really want to make sure that we continue to hammer all the different ways to get free help. We've integrated some QR codes on our print ads here and some of the other features that we have throughout our campaign. And this goes to our Get Help page on the website where folks can find all the ways they can get free help, right? Whether that's calling our call center, going to get free in-person help at one of our Navigator locations or the 2 additional enrollment locations that we'll have during OE this year, the enrollment fairs, live chat on the website, all those good things. And then I think we're going to go ahead and show you some TV ads, and then we can have any discussions that you'd like about the actual creative and the message. And then we'll move into where these messages will appear throughout the state.
It's time. This is the year to consider your health coverage options, to look at more choices, to get enrollment help, or see if you qualify for financial assistance. Access Health CT is here for you, all of you who might need options for health coverage. If you've looked before, look again. If you've enrolled before, choose again from new options. For individuals, families, or small businesses, with dental options too, we're here to help at accesshealthct.com.
Es hora. Este es el año para considerar sus opciones de cobertura de salud, para ver más opciones, para obtener ayuda para la inscripción o ver si califica para asistencia financiera. Access Health CT está aquí para usted, todos ustedes, que podrían necesitar opciones para la cobertura de salud. Si has mirado antes, mire otra vez. Si se ha inscrito antes, elija entre nuevas opciones. Para individuos, familias o pequeñas empresas con opciones dentales también. Estamos aquí para ayudar en accesshealthct.com.
This is an important announcement about lower-cost health coverage now available in our state, only through Access Health CT. There are still great subsidies available, so more people than ever before can qualify for financial assistance. It's the perfect time to take a second look to see if you qualify for quality health coverage at a lower monthly cost. Compare your plan options online, over the phone, or in person. You can find help at accesshealthct.com.
Este es un anuncio importante sobre cobertura de salud a un costo más bajo ahora disponible en nuestro estado, solo a través de Access Health CT. Siguen disponibles grandes subsidios para que más personas puedan calificar para asistencia financiera. Es el momento ideal para reconsiderar y ver si calificas para cobertura de salud de calidad a un costo mensual más bajo. Compare sus opciones de planes en línea, por teléfono o en persona. Encuentre ayuda en accesshealthct.com.
Thank you for the multimedia help, Margin. Before we move on into where this media is going to be placed, is there any questions about the messaging at all? I see a hand raised.
Hi there. The only question I have is, the information at the end of both packages, which is the deadlines and the dates, they seem to flash by relatively quickly. I don't know if it's going to linger at the end a little bit. Or whether this is the complete package and it ends that quickly. Maybe make it more prominent.
So it was a little choppy in how it's featured, but that end slate does have that information. In the future, we can definitely make sure to have that be a little bit more robust, for sure. Any other questions?
Thank you.
All right, we can move on. Now we're going to talk a little bit about the actual targeting for this year. So again, now that we've been around for 10 years, we know a lot more about our audience, right? And so what we've done is we've really relied on a data-driven approach to help us figure out where our ads are going to appear. So as I talk about this targeted approach, 60% of our buy is going to be weighted towards specific communities and zip codes across the state based on data. 40% of the buy is going to blanket the state. So even if certain zip codes don't appear in our targeted plan, it does not mean that they are not going to see our campaign. So let's talk about the zip code targeting. We use the uninsured data that we have, as well as public health emergency data, to make sure that we're targeting high populations where there's a high density of uninsured, and then also a high density of folks that are going to be redetermined at the end of the public health emergency, because that's coming up. We don't know exactly when, we can anticipate when it might be, but we know it's probably going to be fairly soon over the next couple of months. So we want folks to know who we are and where to go when they need help. to figure out what they qualify for in terms of health insurance so that they stay covered. I'm going to jump down actually to the second main bullet before I talk about the third sub-bullet in the first section of this slide. We also want to make sure that we're targeting our messaging to certain specific communities, specifically those that are underserved in communities of color. So we're making sure that we're using a high percentage of the Hispanic media here in Connecticut. That includes TV, radio, print, and interestingly enough, based on our research, this population also indexes really high with Hulu use, so streaming TV. And so we're there in Spanish as well as English this year. We are also, targeting Polish audiences with print and radio, and then also targeting the Black and African American audience. This is a little harder to do because they don't have as much media specifically for them as the Hispanic audiences do. That doesn't mean there's nothing that we can do. So we really relied on this data-driven approach again. So yes, we're going to be on some cable, things like BET, but we also need to make sure that we're in certain neighborhoods, right? And so we looked at data again. It's a bit of an eye chart on the screen, I recognize that. And so I'm going to walk you through really our approach here. On that slide, on the left-hand side is the top 50 zip codes within Connecticut with the highest percentages of African Americans that live in those neighborhoods. What we did in the middle is we layered on our data. And if we found that we were already in those neighborhoods because it was high population of uninsured or because of high populations of folks that will be redetermined at the end of the PHE, we made them red. That way we could discount them because they're already in our plan. And over on the right-hand side, you'll see some light blue numbers, okay? And those are the neighborhoods that weren't already in our plan for the uninsured and the high densities of folks that will be redetermined at the end of the PHE. So those are the zip codes that we actually added in to our targeting strategy. And so really those additional 12 zip codes that you see all the way on the right-hand side of the screen were added to the zip codes of the uninsured and the high densities of the folks that will be impacted by the end of the public health emergency. So there's some information on how we're targeting this year, and you can go ahead and advance the slide, Marcin. I wanted to provide just a little bit more data too from our research report. So we, where we choose to decide where our media is going to be. There's been a lot of discussion about this year over year, particularly with TV, right? Do we need to be on the major broadcast networks and cable anymore? Do we need to be on streaming TVs, the Hulus of the world, that kind of programming? And ultimately, right, we look at data to help us decide this. Over on the left-hand side, you're going to see a source from Scarborough. That's a Nielsen company where it's monitoring the Hartford market. And so this data was taken in August 2021 through March of 2022 this year. And what it found is 85% of the Hartford market streams their television. So when we have our discussions about cord cutters, where are they? Can we just go to streaming? Ultimately, our plan does include the major broadcast networks, some cable, but the vast majority of our TV spend is actually on streaming television. And it's because our data tells us so, and it's through the entire state, not just the Hartford market that our research included. But just some snapshots here to help you understand why we're making some of the decisions that we are. Then moving into the center, there's been a lot of news about this recently. In fact, there's the updated news that the bus ridership in Connecticut has even surpassed pre-pandemic levels. This data point from when we were doing our research and coming together with our plan showed that there were almost 7,000 rides per month, right, in May, 700 more rides per month compared to the previous year in May 2021. And this is in large part because of the gas tax holiday that made riding the buses free in Connecticut. That's not going to be permanent, but what we know right now for this enrollment season is that having out-of-home concepts or marketing out in the market is really going to be helpful. And that's what bus shelters are. So we're going to be in a ton of bus shelters throughout the state. That's what out-of-home media is. Think also billboards, things like that. And so we're going to be on bus shelters, which is really great because we know people are riding them. So they're sitting there, they're waiting for the buses, they have their captive attention. But more than that, they act as mini billboards in communities. Even if you don't ride the bus, even if you're driving by, you're going to be passing by those bus shelters and consuming that content. And so that data is from the Greater Bridgeport Transit Authority this past July. And then moving to the right-hand side of the screen, just some good statistics about out-of-home marketing. Just to complete the story, we are going to be in some billboards. So we're going to be in digital billboards in the Hartford, Bridgeport, and New Haven communities. And, that really mirrors a lot of what we did from our Broker Academy strategy too, right? Because that's where high populations of the uninsured are. But we also want to be in communities with out of home that might not have a billboard. Think the Tollins of Connecticut. And so one of the things that we're doing this year is we're actually renting out mobile billboards. They're big trucks that are backlit even at night, and they have messaging all across the side and the back of those trucks. And we go and we park them in big shopping centers, grocery stores, Walmarts, bank parking lots, things like that in communities. So we can have that billboard type of effect for folks, even when there's not a billboard in that community, which is really exciting. So in terms of out of home, what impact does it have? Well, this sourced from a Harris poll in November of 2021, so last year, 43 consumers had visited an advertiser's website after seeing an out of home ad. 39% searched for more information online. The same amount had made a physical purchase, so actually converted, and 28% even downloaded an app. Yes, it's true. The millennials and Gen Z folks are more apt to do that, but we need to make connections with them, especially as they're aging off their parents' plans and need to find a plan for themselves. So folks will go through a lot based on what they see out in the market and out in the wild, right, with your advertising. So go ahead and advance the slide, please, Marcin. All right, we're almost done, folks, I promise. I want to talk about the full media mix here. We will be on TV. The out-of-home channels that I just talked about, right, are great bus shelters, billboards, as well as those mobile billboards. We're going to be in print ads this year. We're going to launch with The Current, and then we're also going to have all of the minority papers that reach the Hispanic, Polish, and African-American audiences. We're going to be on radio, and I'll talk about TV and radio in a little bit more depth in just a moment here. We also have a lot of search engine marketing, right? So when people hit the Google machine or other search engines, we want to make sure that we're popping up when they're searching for solutions about health insurance in our state. A big social media and digital presence, which will be the main blanketing of the entire state, although our radio and TV will also help with that as well. So down at the bottom here, I have a couple of pie charts. I'd like to focus you in first on the center chart. This is the percentage of our buy across all of that media mix. And I want to talk a little bit about radio and TV separately. So on the left-hand side, you're going to see radio. We have streaming, and then we have terrestrial. Terrestrial is slightly less than our streaming buy. And that really just stands for, the AM, FM radio, what you might have in your car if you don't have Sirius XM, or what you had on your clock radio growing up. Right, that's what terrestrial radio is. And then streaming are the Pandoras, Spotify's, channels like that. And we're finding that the vast majority of households do have an account for those streaming radios, and they use them. And they even use them outside of the car in different places. And so we want to make sure that we're there and really relying on our data-driven approach. So that's why the spend is a little bit more towards the streaming radio rather than terrestrial. And similarly, moving over to TV, you'll see that pie chart on the right-hand side. The biggest slice is green, right? A little bit more than half. And that stands for over-the-top or connected TVs, OTT or CTV. OTT means that your TV just needs a little device to access the internet so that you can watch something like Hulu, right? Like an Amazon Fire Stick or a Roku device, maybe you've heard of. And then smart TVs are just a little bit newer. They don't need that extra device. They actually connect directly to the streaming channels themselves. You just toggle to a different menu, and then you can go ahead and you can choose whether you want to watch Hulu, Apple TV, Netflix, what have you. Before I move on, we are not on Netflix. There's a reason for that. They don't currently have an ad-supported model for us, but they are rolling one out this year. So I'm very excited to see what that looks like next year. And then filling in the rest of the pie for TV, you'll notice a couple of other slices. So you'll see Fairfield County Cable in orange. You're going to see the Hartford DMA broadcast in blue. And then strangely enough, Danbury actually has their own cable network here. And we know that we need to be there, right? Because they do have a high population of the uninsured. And then we have our Hispanic broadcast. So think your Telemundo, your Univisions of the world, right? That's where that kind of falls into play. So that is the whole media mix. And I just wanted to make sure that we took a little time to talk about TV in particular and then radio as well, because it's similar, since that's been a topic of conversation over the last couple of years. And then another slide, Marcin. This is the last slide. Folks, this is just our Gantt chart of when we're going to be in market by those specific channels, right? The different type of media. I'm not going to walk through the whole thing, but of course we'll make this available for you so you can have this to reference. I just want us to talk a little bit about the first couple of lines. You'll see linear TV there in English and Spanish. It's the only other TV term that we didn't go over. That's your appointment viewing. That's when you log, you just watch your major broadcast networks or cable. That's what linear TV is. And so we made a big scale back this year, and we're only there the first and second week of December leading up to that first deadline. And the reason for that is it gave us more money for us to put on that over the top and connected TV, because that's what the data is showing us is the better buy. That is different this year. That's the biggest change, and we'll let you know how that's working out. And that's all I have for you. And I'll take any questions about our targeting and the different media channels that we're using.
Mr. Chairman, one quick follow-up to Caroline's presentation. Steve, in case it wasn't clear, we're going to look at, if we could stretch out the end of those two TV commercials to make sure the average viewer will have enough time to consume the information. And so we're gonna look at. We should be able to, but I'm not the media person, but we should be able to, and hopefully that'll. Cause I noticed that also when we reviewed these on Monday and Tuesday. Right. And also, as you might imagine, right now, TV ads are very expensive because of the election that's going on. So a lot of the local channels are charging a premium because of competition. So we have to be very strategic and very targeted about how we spend our dollars. And as you can tell from the focus here, we are really making a hard push to target the uninsured, and also targeting the end of the public health emergency, because the last thing we want in this space is to have anyone have a gap in coverage because of the end of the public health emergency, especially those who are chronically ill and are also on a chronic maintenance drug.
Thank you, James. Matthew, you have a question just before we do that. Is Julie Andrews on? And
Yes,
if
she
so,
is.
I'm just conscious that we're a little behind schedule, and I just want to make sure that you can still accommodate our schedule.
Yes, I'm on, and there's no problem.
Okay, thank you very much. I appreciate that. Matthew?
Thanks. A couple of things. I really appreciate the focus and the targeting on the uninsured populations that you sort of walked through. I think that's really great. I had two questions. One, in print, are we doing anything in the on like those free weekly community papers, like the Rare Reminder and like the East Hartford Eye or Gazette or whatever it's called? I'm convinced that those papers get higher readership in certain communities than the Hartford Courant. No offense to the Courant.
Yeah.
Or they sit around, right? They sit around for a while in a way that an ad can get additional resonance. So I wonder if we were doing anything in those.
Yeah, so we don't have them in our advertising. There's just not enough to go around to have every paper, unfortunately. But we have very good luck with our earned media and the reminders of the world in those papers. And we typically get some really great placements. In fact, they pick up our press releases and print them as is, which is delightful. And so that's part of our strategy and making sure that those folks are, noted within our earned media. And so they're on all of our media lists, and we've had really good traction with them in years past.
Okay. And then my other question is, do we expect the carriers to be doing their own advertising around open enrollment? Obviously, they've got some vested interest here. And to what extent could we pair up or match up, divide and conquer the advertising world in that space?
It's a great question. I know that the local, or our carriers have actually amped up their efforts with advertising this year, especially to support Cover Connecticut. In full transparency, I'm not sure at this point in time what their efforts are for open enrollment, but I think that that's a great piece of suggestion and advice to work more closely with them in the future and see if there's a way that we can be smarter with our buy, right, and kind of complement one another. It's a great point. Thank you.
Thanks.
But Matthew, you should be noted that they are fully aware of what we're doing. Because our OE plan readiness, we have meetings with them on a regular basis where we share broker information. We share with them where we're going to be in all of our community-based organizations. And also we share with them what our marketing and outreach strategies are for open enrollment. So they know what we're doing. So so they can develop their own strategy to augment or supplement what we're doing.
Great.
Thank you. Ted Doolittle.
Yes, thank you. Ted Doolittle, Office of Healthcare Advocate. So I've been on the board for a while, and we always have had a real strength in these board presentations. They've been very good. But I just want to say thank you to Caroline and Catherine for just really, really good presentations today. Things that I'm going to really take some time to sit with afterwards. I appreciate it very much. One quick comment on the cable versus cord cutters and never orders or whatever the names are. Obviously, when people come under financial pressure, right, one of the first things you can look to without changing your lifestyle much is to cut the cord. So I think, leaning into the those families is a wise move. But my main message is thank you very much for two really good presentations. Thank you.
Appreciate that. Thank you.
And then I think there's a third leg to this stool, and that's Tammy to talk about outreach.
Yes. Good morning, everyone. Tammy Hendricks, Director of Health Equity and Outreach here at Access Health. I just wanted to thank Caroline as well for sharing those targeted zip codes because marketing and outreach, our teams work very closely together so that we can maximize our efforts, right? So those zip codes that we identified play a key role in helping us reach those areas of high need. And those areas typically have, higher uninsured rates, and they have an audience that is harder to reach. So while marketing is helping us get that exposure across the state, the outreach team is focused on those face-to-face interactions and education in communities throughout Connecticut, right? We work with our community partners, consumers, and the broker community. So just wanted to add that piece in there. But before we get into open enrollment, I wanted to cover some pre-open enrollment events that we've held so far. I know James mentioned it briefly in his introduction. But it's really important for my team to engage with the broker communities and community partners, as well as consumers, right? We want to constantly remind them what's new, what options they have this year. So a big focus for us has been education as we prep for open enrollment, right? So specifically this year, we want to make sure that they're comfortable promoting and that they're knowledgeable about Covered Connecticut, and that they understand the significant impact of the Inflation Reduction Act, so that they can tell consumers that there's more help available, all of those good things. So we started out with our regional breakfast conference week. We had 4 meetings in Hartford, Norwalk, Groton, and New Haven. So this year we decided to kind of restructure the community conference, the typical community conference that we usually do. We wanted to accommodate more in person this year, which was great. So we connected with a lot of brokers, community partners during these meetings. We had representatives from the carriers in attendance, right? They've been joining us for our meetings this year, and they'll be involved in open enrollment for all of our in-person events. They typically show up and they table at those events as well. So we even had some Broker Academy students join these meetings. So it was just a really great opportunity for us to learn the needs of the brokers, our partners, and how we can improve on our end. Really got some helpful suggestions that we were able to bring back and share with our teams. So a big thank you to all the presenters that took the time out. We talked about Covered Connecticut. We talked about the public health emergency, info about the plans, improvements to the applications. DSS talked about immigration, which is always a popular topic with our community partners. So all these presenters presented 4 days in a row, and I know it wasn't easy, but it was very well received. So overall, we had 231 attendees, 76 in person, 155 attended via Zoom. But, you know, we have to think of the impact, right? It's bigger than 231 attendees, right? These folks are going back to the communities, back to their agencies and sharing this information. So significant impact there, and the meetings were, it went very well. This year, it was especially meaningful because we were able to distribute 4 community awards, right? As opposed to the one that we usually do for a community conference. So we did a community award for one in each area. The first 2 awards went to East Hartford Library and Stamford Library, 2 key partners for us, right? Helping us with enrollment locations almost every year for the past couple of years. And they've also allowed us to host other events, educational events, and always accommodating to us for press conferences, even last minute. Really great partners to us. The next award, we went to Community Health Center, and this was for the Groton area. And they were critical partners for us during COVID and now. They initially helped us get signage at the Rensselaers Field, where they had the huge COVID vaccination site, right? 10,000 cars daily going through there. And they really kept us connected in the Groton and New London area, which we're still building up more of a presence there. And finally, we gave the last award to Project Access New Haven. They were our navigators for 2 years during COVID. Unfortunately, they couldn't be a part of the program this year, but they continue to work closely with us, right? Their executive director is a member on the Health Equity Committee. So true advocates for their communities in New Haven and Bridgeport. And they continue to work with us tremendously. So overall, great events. Happy we were able to get folks together in person, bounce some ideas off of each other. And it was also good practice for hybrid meetings, which can get a little difficult to balance. Finally, we're wrapping up this week with our Healthy Chat presentations. These are informational, educational presentations we do for consumers, specifically to just go over Access Health, what we offer, how they can get help. So we hosted 3 events this week, one in East Hartford on Tuesday, one in Danbury last night, and we're wrapping up our presentations with a virtual call tonight. So we've had over 300 RSVPs so far. We have over 200 folks RSVP'd for the call today, which is exciting. And I really attribute that to our engagement with community partners. They're helping us spread the word, as well as our marketing team really helping to get these events out there for the public. So we're excited. We're having more in-person options this year than previous years, really due to COVID. But as we continue to incorporate more in-person events, we're seeing more attendees. We're noticing better engagement, which is really the momentum we need to move into the open enrollment period. And I'll pause here if anyone has any questions. Okay, great. So now on to open enrollment.
No, go please.
Oh, sorry. Now on to open enrollment. This year, we're expanding, of course, the in-person enrollment opportunities, continuing our theme of engaging folks more in person. So right now, we're really just continuing to encourage consumers by letting them know there are different options for enrollment, whether that's through our improved online experience or getting help from the call center, and various ways to get help in person, right? We have our CACs, we have our brokers who just completed their trainings. So lots of options. So let's start with our enrollment locations. We're returning to Stamford and East Hartford libraries to serve as enrollment locations. These are recurring from previous open enrollments, but they have consistent track record for high turnouts. So we'll be at Ferguson Library in Stamford Monday through Friday, 10 a.m. to 6 p.m. Then we have Raymond Library in East Hartford. We'll be there Monday through Friday, 9 a.m. to 5 p.m. These are static locations. right? So we'll be available all day for enrollment help. For our enrollment fairs, these are pop-up events, right? So we can hit different areas of the state. Going back to the slide that Caroline covered with these targeted zip codes, we chose these locations based off of the current data. So, right, we need to have a more targeted effort. And we also base these locations off of feedback that we get from community partners, right? So some locations are chosen because of the need. So we have 14 fairs that will be held during the week after hours. So Monday through Thursday, 5 to 8 p.m., getting folks after work hours. And we'll also have 7 fairs throughout the OE period on Saturdays and Sundays from 10 to 1 p.m. So wrapping up here, we have our new navigator sites. We expanded the program this year, right? We have a lot more reach throughout the state. And not only do they help with our yearly community outreach, but they also offer in-person help all year round, not just through the open enrollment period. So we have Community Renewal Team in Hartford. We have Community Health Center Association of CT. They have locations all over the state, which is why they're really important partners for us. But we chose Danbury, Willimantic, Norwich, and New London locations to serve as navigator sites, right? So folks can go in, get the help to get enrolled, and also get medical services if needed. We have the Greater Bridgeport Area Prevention Program in Bridgeport, and finally we have new opportunities in Waterbury. So significant coverage throughout the state. We'll have in-person enrollment opportunities in all counties, right? Helping us maintain that presence in hard-to-reach communities as well as other communities in Connecticut as well. So that's all I have. I'm happy to answer any questions. Very good.
Thank you, Tammy. And let me just echo Ted's earlier comments and extend them to you. Very helpful presentation. Very useful. Thank you.
Thank you very much.
Julie, you've been patient. Julie Andrews, if you would take the floor.
Good morning, everyone. I'm Julie Andrews with Wakely Consulting, located in the Denver office. If we go ahead and advance the slide. So today we'll be covering several topics about the plan offerings in 2023 and how the rate changes are going to impact enrollees and as they go into open enrollment. On the next slide, the analysis of the impact of 2023 rate changes to be presented today are based on the final rates approved by the Connecticut Insurance Department. And any weighted averages or analysis is based on enrollees on the exchange as of September 2022. So to start off with, we're going to go through on the next slide, talk about plan offerings and enrollment mix. So as was mentioned earlier, enrollees will have fewer gold and bronze choices in 2023. Anthem will be offering a new gold and bronze plan in 2023 while discontinuing one gold plan. And CBI will be discontinuing a gold plan and 2 bronze plans. So we'll have a total of 25 plans. There are 3 issuers that will continue to offer plans on exchange. There's the Connecticut Insurance Company, Inc., or abbreviated CICI, which I may refer to as Chi-Chi during this discussion, as well as Anthem, and Connecticut Benefits, Inc., which you'll see abbreviated as CBI through the presentation. Before we start, let's go to the next slide and talk about the overall consumer cost. It's important to understand how, in addition to premium, the metal tier election and eligibility for cost-sharing reductions is a driver of consumer costs and is an important part of the overall enrollment decision. A plan's metal tier is defined by its actuarial value as calculated using a federally provided tool that evaluates all cost-sharing inputs such as coinsurance, copays, and deductibles up to the maximum out-of-pocket to establish the actuarial value. So the actuarial value therefore can be described as the portion of claims paid by the carrier versus the portion paid by the consumer. In 2023, CMS narrowed the permitted ranges of compliant actuarial values by increasing the lower bound, and this necessitated the modifications of several plans to reduce consumer cost sharing to comply with the new narrower range. So just for an example, in a standard silver plan, as shown on the table in the bottom right, the carrier would be responsible for about 71% of the medical claim costs, and the consumer, the balance, or 29%. While for a bronze plan, the carrier would only be responsible for about 64 to 65% of the claims costs. The consumer's responsibility is always limited each year by what we call the maximum out-of-pocket, which will vary by plan, but may not exceed $9,100 for 2023. And then, and premiums are not a component of that cost-sharing cap. The ACA also provides for cost-sharing assistance to those consumers enrolled in a silver plan for those that have that are below 250% of the federal poverty level. And that's graphically shown on the left, on the bottom. Consumers that may qualify may be eligible for reduced cost sharing, such as lower copays, coinsurance, and deductibles, thus increasing the standard silver actuarial value from that 70 to 70% range to 73%, 87, or 94% actuarial value, as represented in the graph and dependent upon their percentage of the federal poverty level as defined by their income. This information is independent of any state program that also may impact cost sharing, such as the Covered Connecticut program. If we go to the next slide, we can look at where enrollment has been historically. The silver and gold plans have gained in enrollment through 2022. The left four columns show the metal section for on-exchange enrollees by year. So in 2021, we saw a reversal of the prior year's trend with an increase in the silver plan enrollment and an increase in gold as well into 2022. We're seeing this across the nation as well, likely driven by the enhanced subsidies that became available in 2021 and 2022 with the passage of the American Rescue Plan Act. The right four columns show what percentage of enrollees in each metal plan elected the lowest premium plan option available that year. So for example, on a silver plan, only 70% of the 2022 enrollees picked the absolute lowest silver cost plan. So given that the results are not 100%, we can conclude that other factors are obviously considered by enrollees than just premium cost when they're selecting their metal coverage. On the next slide, while most of this discussion is going to be focused on individual coverage, Blakely did review the small group plan offerings available on the exchange. There are 2 carriers offering plans with a total of 10 plans. The same 2 issuers will be participating, but there will be 1 less silver plan available from CBI in 2023. So now let's get into the meat of the discussion and talk about the rate changes. So in this discussion, we will look at the premium rate changes as approved by the Connecticut Insurance Department for 2023. And any rate changes presented in this section are prior to any premium subsidies. So rate increases for enrollees continuing enrollment in their current 2022 plans will experience an average increase of 12.2%. Enrollees in Anthem plans will see an average 7.1% increase, while individuals enrolling in a CBI plan will see an average 13.9% increase, and finally 15.5% for those in GG plans. Rates will vary widely by individual plan from 2.3% to a 29.1% increase. On the next slide, there are several drivers that are contributing to the average 12.5% premium increase presented on the prior slide. One of the largest drivers of increases has been reflecting the emerging experience in the rate development process, as well as pricing trend, which will reflect the increase in the number and complexity of services sought by covered enrollees. Inflation, and as well as the inflation of the cost of services year over year that will be impacting carriers or impacting claims. COVID continues to play a role in driving anticipated healthcare costs. Carriers included up to 1.5% of premium for ongoing costs associated with administering the vaccines, testing requirements, and treatment costs that are not covered by the federal government. The bottom table kind of contains the minimum loss ratios by carrier and overall for the past 4 years. The minimum loss ratio reflects, at its simplest, the ratio of claims to premiums and reflects emerging experience. For 2021, the overall average MLR is 96.2%, which means out of every premium dollar, roughly 96 cents went to pay claims, and 4 cents were left on hand to cover everything else, such as administration costs and investments for the future. In this way, the MLR also acts as a gauge for the health of the insurance market, where one can observe if premiums have been sufficient to cover the cost of claims and contribute to the cost of administration while not being excessive. The ACA does require that the minimum loss ratio not fall below 80% over a 3-year period. So you can see that, prior to the pandemic, the ratios appeared fairly healthy at around 86.4% for the individual market. With the pandemic and the deferral of a lot of services, the loss ratios fell to 82.7%, but there's been a significant increase in 2021, which 2021 was used by all issuers in defining the base experience for developing 2023 rates. So one can see the connection to what was happening in 2021 to the requested rate increases. And what we're seeing in 2021 is not unique to Connecticut. It's something that we're seeing across the country as experiences emerged in 2021 and 2022 with ongoing COVID costs, as well as a resurgence of utilization as people seek care that was deferred through the 2020 pandemic year. All right, well, if we go to the next slide, we can go and look at the nitty-gritty of all of the plans being offered and the rate changes by region. So Chi-Chi and Anthem did make changes to the regional rating factors for 2023, producing different rate changes by county. The Platinum plan on average is increasing by 19.1%, while Gold plans are increasing on average by 14.8%, and Silver plans are increasing by 8.7%. I've put a box around the Silver plans on the bottom. If we focus in on those 2 Silver plans, we can see, like focusing in on Fairfield County, that the rate changes are going from 6.7% to 10%. The changes to the Silver plans are doubly important as they are used to determine the benchmark premium for subsidies, which will be discussed further in this section. And on the next slide, not to be forgotten, are our Bronze and Catastrophic plans. So the average plans increases for these plans are much higher than the richer plans shown on the previous slides. So the Bronze plans are increasing on average 32.4%, while the Catastrophic plans are increasing 20.8%. So by county, looking at the changes, they vary from about 8.8 to 13.6%, dependent on enrollment. And then if we go to the next slide and just to switch back to small group, Anthem small group plans on the exchange decreased by 1.4%, while CBI plans are increasing on average 15%. The plan changes will go from a negative 3.5% to 15.1% as small groups renew in 2023. I'm sorry. So next, when consumers make a decision which plan to select, there's many more considerations that go into the mix, not such as plan design, network, or their healthcare needs. So this analysis is really only going to focus directly on the measurable impact of changes, which is the premium and the federal subsidies available to consumers. Brokers can be used to help advise consumers on their needs and plan selections. In addition, the decision support tool on the exchange can also help consumers navigate their shopping experience by assisting them in evaluating premiums as well as estimating their healthcare costs for the upcoming year. On the next slide, the premium consumer impact analysis uses carriers' plan mappings for any discontinued plans, and weighted average calculations are based on the exchange enrollment as of September 2022. Premium changes will vary widely by age, county, income, plan selected, as well as household size. Here we provide some important definitions of components that are used in evaluating the consumer impact of premium changes. The benchmark plan is defined by the second lowest cost silver plan for essential health benefits only. The benchmark plan and the plan selected by the consumer define the advanced premium tax credits paid by the federal government and may be referenced as a subsidy. We also want to recognize the Covered Connecticut program that started July of 2021. The impact of that program, though, has not been incorporated into this analysis. And next, there are several drivers that impact a consumer's subsidy from year to year. And these 5 are the most important key elements that are the driver. So on the next slide, we're going to talk about the benchmark premium plan and the changes. The plan that represents the benchmark premium plan is changing in 5 of the 8 counties, and these changes will vary from 5.2% to 11.7%. So since the benchmark is increasing in all counties, the available subsidies are also increasing. So if you look at the next slide, you can see the change in the plans and the carrier offering that plan, as well as the change in the benchmark premium. We've also presented the 2020 enrollment in counties so you can get an idea of the number of individuals that will be impacted by the benchmark premium change. So now we're going to transition to a detailed example of consumer impact on a sample household made up of just a single individual. So we're going to look at Michael, who is 44 this year and whose income is 300% of the federal poverty level. For this individual, benchmark premiums are increasing 12%, which includes the impact of aging, since Michael's going to be 45 in 2023. Michael's subsidies are increasing on average 15%, and on average net premiums are increasing by 6%. So if we go to the next slide, we can look a little closer and just focus on an example as if Michael lived in Fairfield County. His benchmark premium is increasing $83 or 12%, reflecting his older age. His subsidy is increasing by a similar amount or of $72 or 15%. And the result is that his net premium in the benchmark premium will increase $11. So he'll be going from $195 to $206, which is represented in the far right columns. While the benchmark plan is not changing in Fairfield, the analysis assumes Michael would change plans in those counties where it does differ. So let's look at some additional scenarios for Michael. We'll look at an example. If he was enrolled in the lowest cost silver plan, which 70% of the individuals are enrolled in the lowest cost plan in 2022, and then enrollment in the lowest cost bronze plan. So the first example on the next slide is we're following Michael through enrollment in the lowest cost silver plan. The lowest cost silver plan is remaining unchanged for all counties from 2022 to 2023 for all counties except New London, Toland, and Windham. The premium for the lowest cost silver plan in Fairfield County is increasing by 14%. The difference, or $87, which is the difference between those middle columns, the $632 and $719. The net result is a net premium increase of 10% or $14. Since the lowest cost silver plan is remaining unchanged in Fairfield, there's no shopping opportunity. But if Michael lived in Windham County, for example, which is the bottom row, he could switch to the silver PPO standard pathway plan in 2023 and reduce his net premium by $19 from the $206 to $187 to the $187 on the bottom right. Now let's look at a lowest cost bronze option. The lowest cost bronze plan is being discontinued in 2023. So members enrolled in that plan will be required to shop for new coverage. An example, we assume that they would auto renew or select the 2023 lowest cost bronze plan, which is the same in all regions except Fairfield County. The premium for the new lowest cost bronze plan in Fairfield County will be higher by 30%. So an increase from the $491 to $639. So a dollar increase of $144. The result for Michael is a net premium increase of over 1,000%. Or $76, which is the difference between the $80 and the $4. Since there is no change or no new lowest cost bronze plan with the discontinuing plan, there really isn't a shopping opportunity, except that with the plan discontinuing, all individuals will need to look for a different plan in 2023. If we go on, I'd like to focus in on another example. We've got two more examples with further detail to demonstrate how consumers can be impacted differently and how the variant options they may have that they could use to mitigate and increase any increase in their premiums. So the first example we're going to look at is focusing on Ted, who is currently 28 and has an income at 200% of the federal poverty level. Ted's currently enrolled in the lowest cost silver option, and because of his being under 250% of the federal poverty level, he is eligible for cost sharing reductions based on his income. So let's focus in on Ted's on the next slide on the table. So Ted's current premium is $6 in 2022. So that's the orange square. If he does nothing and auto renews into the same plan, his premium will go up to $5. Will go up $5 to $11, which is the green square right next to the orange square. Ted could switch to the lowest cost gold plan, which would have a minimal impact on his premium. Because the gold and the silver plan are so similarly priced. But because Ted is eligible for cost sharing reductions, moving from his current plan at an approximate 80% actuarial value to the gold plan, which is at an 80% actuarial value, would mean higher cost sharing for him in the form of higher copays, coinsurance, and deductibles. Using Wakely's proprietary database of individual ACA claimants, we found that a consumer like what Ted would have monthly out-of-pocket costs of $50 in a gold plan, which is $21 more a month than his current plan. So, that change to the higher cost sharing may not be in Ted's best interests. Likewise, Ted could switch to the lowest cost bronze plan, reducing his premium to only $1 per month. But similar to the gold plan, enrollment in the bronze plan would likely mean he would have more out-of-pocket cost sharing. And in this example, $30 more per month. Now let's look at another individual. I'd like to talk about Karen's situation. Karen is currently 55 and has income in excess of 400% of the federal poverty level. She's enrolled in the lowest cost silver plan option available also. But prior to passage of the American Rescue Plan Act and the Inflation Reduction Act, Karen would not have been eligible for subsidies at an income in excess of 400% of the federal poverty level. So let's go on to the next slide and look at the table. So Karen's premium after subsidies at the beginning of 2022 is $315. Without the Inflation Reduction Act, her premium would have been $1,010. So if she does nothing and auto renews to the same plan, her premium will go up $4 to $319, which is the box next to the orange box. Karen could switch to the lowest cost gold plan, which would increase her current premium by just $1 to $320. Karen would, however, benefit from the richer actuarial value of the gold plan. At an 80% AV as compared to the silver standard option she's enrolled in has a 70% actuarial value. So Karen's not eligible for cost sharing reductions. So her estimated monthly out-of-pocket healthcare costs would decrease by $14 in the gold plan. So looking at the bottom row, she would go from about an estimated $95 per month out-of-pocket cost to $81 as Karen could also switch to the lower cost bronze plan, reducing her premium to only $190 per month on the far right column. Her cost sharing would increase by moving to the less rich bronze plan, which has an actuarial value of 65%. But when you take a look at the combined net premium and estimated monthly out-of-pocket costs, so combining the $190 and her estimated $108 monthly average out-of-pocket costs, her total costs would be approximately $298, and so would be a lower total cost as compared to the other plan options. There are, of course, many considerations that would need to go into Karen's plan choice decision besides just the costs, and Karen should work with her broker or utilize the decision support tool to weigh the best options for her in 2023. So that is the end of the presentation. I don't know if anybody has any questions. I was watching for hands raised during and I didn't see any, but I'd be happy to address any questions.
Mr. Chairman, one quick comment.
Sure.
Thank you. We are going to put the complete report on our website, and we're also going to send it out to the board right after this meeting. All right. So if you have questions after the meeting, please you can send them to Susan or me directly, and we'll get them answered to you. But also, one of our biggest concerns, and I'm going to play the role of Paul Philpott. Paul always asks the questions. What about the unsubsidized members? And right now, about 16% of our of the QHP purchases on the exchange are unsubsidized, and so which means they will be absorbing the entire cost of the increases. So we are concerned about that, and we have put together a very targeted outreach effort to those 16,000 plus, meaning that we've identified, we know who they are, and if they have a broker, we know who the brokers are. So we're going to design specific communication letters, emails, and text messages to them, encouraging them, as well as their brokers, encouraging them to come to the exchange and shop to see if there's a better option, a lower cost option that will still meet their health insurance needs. At this point, that's all that's within our powers where we could. But again, we're going to reach out to them aggressively to encourage them to come in and shop and try to pick a plan, maybe lower cost, but that still meets the medical needs, the health insurance needs. I just want to put that out there. That's a question and concern that Paul always has every year. I just want to make sure the board is aware that we are keenly aware and focused on helping those and to manage their health at the most lowest possible cost. Thank you, Mr. Chairman.
Thanks, James. We do have some questions. Ted Doolittle.
Thank you, Mr. Chairman. Ted Doolittle, State Healthcare Advocate. Can we go back to slide 25 for just a moment? Great, thank you. So when we see the AV ranges here, I just want folks on the call to remember, and anybody in the public who's listening, these actuarial value ranges are very important for the companies to plan their year, and also very important for the insurance department. However, it does not actually reflect the amount that the average consumer is going to see the plan pay. So like, for instance, if you're in a bronze plan, no, this does not mean that your average consumer is going to have 65% of their costs paid by the insurer. In fact, on the exchange, 90% of the folks never even hit their deductible. So they're having an actuarial value that just includes their preventative care. So their real actuarial value is going to be like 4% or 5% or something of that nature. Then if you do get sick or you get hit by have a serious accident, then your actuarial value is going to go up to 97%, because even though you have this huge $6,500 deductible, the $100,000 does get paid by the insurance. So these actuarial value numbers need to be understood for what they are. They're valuable for the companies to understand their planning, and they're valuable for the insurance department, but they do not reflect what a consumer, especially an unsubsidized consumer, is going to experience. Great presentation, Julie. I just wanted to make that comment.
Yes, thanks, Ted. That is correct. I mean, the actuarial values are a tool defined in the statute to help differentiate plans and define different cost-sharing metal tiers.
Commissioner Gifford.
Thank you. I actually just have a request, and I don't know, James, if this is for you or Ted's office, but with all of the attention that was paid to the rate increases this year and the obvious interest, I think it would be really helpful for us as board members to have a little cheat sheet of very straightforward examples like you shared. If you're single and you make this much, here's what's changing for you. If you're in a family of 4 and you make this much, I mean, obviously the permutations of that are endless, but if you could pull out a few of the most common types of examples and then put in plain English for us, what is the consumer experience, how that's going to change, without jargon and all that kind of stuff. Because we get asked a lot to translate the impact of these changes into real world impacts on our Connecticut residents. So that would be super helpful, I know, to me, and I'm sure to other members of the board who get questions about this.
Dr. Gifford, we will absolutely do that. We've done that in the past. And I think towards the end of Julie's presentation, then where she talks about TED and other, well, we'll do something similar to that.
Yeah, exactly.
Right.
That's what gave me the idea, is just to kind of distill those out into a few plain language examples would be super helpful. Thank you.
So, Commissioner Gifford, just to make sure I understand also, you're looking for, which is terrific, and I support, some more information about the all-in costs for certain types of families, including the premiums and the out-of-pocket. Is that what we're
Yeah,
talking about here?
people don't really, as you know, Ted,
Yeah.
people don't really distinguish,
Right.
you know, between, they just, what is their healthcare going to cost them? So, I mean, monthly premiums are one thing, and, you know, maybe it makes sense to divide it out, premiums and out-of-pocket costs, but in plain language, what does this mean in real world circumstances for consumers?
Yeah. Let me just share one thought on that. So if you have a kid who's going through the college experience now, they no longer give you the average SAT score and the average grades. What they do is an interquartile range. They show you a band and they show you where the middle 50 fit in there in terms of the accepted students, what their SAT was at the 25th percentile and the 75th percentile. And so, you know, if you're in the middle of that chunk, you got a good shot. We could do something like that using an interquartile range for all-in costs to show, you never know what your family's history is going to be next year. So all you can do is do your best prediction, but it will show you the likelihood of you being above a certain amount in all-in costs and the likelihood of you being below a certain all-in cost. And that's something that can be helpful also. Just want to make that comment.
Dr. Gifford, we will do our best to create a document that would be as clear and direct as possible so that the average person can make sense of it. And we'll draft it and we'll share with Ted to get his input. Then we'll send it out to the entire board.
So we'll be happy to work with you on that, James.
Thank you.
Yeah, thank you very much. I think it's a very good suggestion. I think the simpler the better in some of these examples, right? It's really for kind of walking around knowledge to say, look, this is kind of the impact this year. So I think that's a terrific idea, and thank you, Ted. Matthew, I may have lost you in your hand raise.
I'm with the Commissioner Gifford and Ted and 100%.
Thank you very much. So one quick question. At what point does it make sense, and when we have the data, to try to actually model in the Cover Connecticut program in these presentations?
Well, the covered Connecticut consumers would have zero premium and zero cost sharing. And it wouldn't change from year to year as long as they were still eligible for the program.
So we'd be good to have that be one of the examples.
Yep, absolutely.
Great. No,
Especially for public consumption, yep.
Okay, no, I think put it in as an example would be great. I think it's, I mean, all we can do to publicize that program, I think, is good. And it's an important initiative by the state, and let's make sure we don't leave it aside as we talk about these things. Thank you very much, Julia, and thank you for indulging us a bit on the timing. We appreciate that. As always, a very informative presentation.
You're welcome. Thank you.
Susan, one day we'll get James to put you first rather than last, but once again, you are our cleanup speaker.
It's all good. So I'm just gonna cover, as James and Dr. Gifford have mentioned, and Katie, the public health emergency unwinding, and then I'll get to my ACA update. So right now we have over 390,000 Medicaid enrollees that are currently benefiting from the extended Husky coverage, excuse me, under the public health emergency. And there was an update last week. The U.S. Department of Health and Human Services announced a 90-day renewal of the public health emergency on October 13th. So now it will go until the middle of January. Now, also to note, the federal government has promised states, because of all the work that this will entail for Medicaid agencies, that they will give states 60 days prior notice before the end of the public health emergency. So if you do the math, if the public health emergency is going to actually end in mid-January, they would need to give us 60 days notice in mid-November. So that will be the next date that we are watching. They do these extensions in 90-day chunks, but they can actually change it. So they could come back and make a decision to have it not go all the way to January. But right now, that is the information that we're working with, and we'll keep watching for November for an update on whether it will actually end in January. As we've also talked about, in addition to the Medicaid extensions, Access Health has continued to delay action on open verification requirements for QHP customers during the duration of the public health emergency. So we've been sending out notices and still encouraging consumers to submit verification, especially on income, as it's so important to get that income correct so you don't have a future tax liability. But we have not taken any action to cut off subsidies or potentially cut off coverage during the public health emergency. So as we've been talking about, we've been partnering very closely with the Department of Social Services to prepare for the eventual end of the public health emergency. And as James has mentioned, you know, our utmost concern is always to ensure that consumers don't have a gap in coverage. You know, there are many people who have chronic health conditions, and we don't want them to wind up at the pharmacy or the doctor and find out that they don't have coverage. So what does all this preparation mean? We will be reverting the eligibility and enrollment requirements to the pre-PHE thresholds and configurations. We continue to plan. We actually meet weekly, a group of us from DSS and the exchange and our IT vendor on planning for the schedule, how this is going to work over the 12-month period once it does start, what the volume will be each month, and the renewal rules. And also very key in all of this is the communication strategy. You know, people have not had their coverage, their Husky coverage end during this period since 2020. So we really are trying to communicate to make sure that we have your most up-to-date contact information so that you will get the notices and get the information once the unwind and the redeterminations do start. And then also in preparation for this, we know that it's going to mean increased volume to our call center. And we have worked with our call center vendor, and normally their staffing, usually in a usual year without the public health emergency, would tend to drop down after the open enrollment period ends. As we know, that volume kind of slows down. Coming up into this period, we have them prepared to have increased customer support available. And obviously, Tammy and her team will be working with our navigators and all of our enrollment partners to make sure that they are also you know, there for consumers as well, and brokers, as we've been talking about the importance for someone who may be, you know, rolling off of Medicaid, coming onto a QHP, and understanding what their options are and looking at their needs and their family's needs to choose the best option. So that is it. I'll take a pause if anyone has any questions on the public health emergency update.
The only point I want to add, as Dr. Gifford asked, maybe next month's meeting, we'll give a more in-depth presentation about the entire the end of PHE preparation communication. So maybe Dr. Gifford, maybe you and me, we get talk exactly who on our teams. Again, put together a very detailed presentation for the entire board about everything that we are doing, will be doing. So the board is fully aware. There's a lot of work that's been going on for about a year on this. So we'll present the summary of all that work and also future work as we prepare for the end of a PHE.
Okay, if there's no,
Chair,
sorry.
Mr. Chair, if I could just be recognized for two quick things. One, fantastic presentation. Thanks so much. I especially appreciate the nuance that you provided about the 90-day public health emergency and how the default is if the secretary takes no further action, it would go for that full 60 days, but that at any point intervening, they can choose to pull the trigger and end it early. That's a little bit of a mismatch. So when people think about 90 days versus the 60 days, it's very important for budget purposes. So I appreciated you making that finite point there. On the point about outreach during the unwinding, I've had a couple conversations with community partners, stakeholders. One in particular, Health Equity Solutions, was very willing to be a partner to review any outreach materials. So to the extent it's helpful, I'd be happy to, if you're not already in conversations with them, make that connection. They've offered to sort of send out any draft materials or correspondence to their network and sort of help co-create it and make sure that it's culturally appropriate and it's hitting the marks for making sure that we're embedding an equity lens in our outreach. So if I can be helpful in making that connection, they have offered to help, and I know they're eager to do so.
Antonio, we'll reach out to them. They're already partners.
Yes.
So we'll connect with them and then share with them the draft communication to get their input. So we'll meet with them as we have done in the past.
And Karen Siegel from Health Equity Solutions is on the Health Equity and Outreach Committee. And we've been, as James mentioned, we've worked closely with her for quite a period of time. So thank you. Okay, if there's no other questions. Sorry, was I cutting someone off?
No, it's Charlie Clipple. Thank you. And let's move to the ACA.
We'll move to the ACA. So as everyone has probably seen in the news, some exciting news. Finally, the IRS issued the final rule last week, busy week, on the family glitch. And this rule deals with eligibility for premium tax credits, which limits, the ACA limits eligibility for a tax credit when a consumer is eligible for another type of affordable minimum value coverage, which could be a government program, but also could be an employer-sponsored plan. So under the IRS interpretation that's been in place since 2013, the test for affordability has been based on the cost of coverage for the employee only in relation to the household income. So not just the employee's income, every member of the household's income. And that's been applied for the employee as well as the family members. Under the new final rule, the exchange will now be able to consider affordability for coverage offered by the employer for other family members in the tax household. So this is really terrific news. The affordability test for the employee will remain the same, using the lowest cost option for employee-only coverage, and the new standard for affordability for the family members, this is tax dependents only, will be based on the cost of family coverage. So we will ask applicants about any employer offers of coverage, both for the applicant and other, dependents in the household. And the lowest cost option for the employee only will be used to determine for the family member. So you could have an employee be eligible for the premium tax credit because the coverage offered to them only to them is unaffordable. And now we're also going to look at what the cost is, the lowest cost for the coverage offered to the family members in the tax household. And now those members may also be determined eligible for a premium tax credit based on the affordability of the coverage offered to those family members. And it could actually differ for the offer for the employee only and for the family members. So we'll really have to, that'll be interesting to see how that unfolds. And one other aspect in this rule is that it also added a requirement that the coverage offered for the family members also meet the minimum value standard, which ties back to those AVs that we've been talking about a lot today, which means that the plan has to cover at least 60% of the allowed costs, and it must also provide substantial coverage for inpatient services as well as physician services. This new interpretation will provide access to subsidies for a great deal of family members that have previously been ineligible, and it's estimated to be nearly 5 million people nationwide, and these are primarily low-wage workers that do not have access to affordable coverage previously. So this is really exciting news. We've already made the changes to our system rules. We've just been waiting for the final rule to flip the switch. So now we will have it on. And as James has mentioned in other areas, we will also be doing outreach so that families are aware of this.
So,
And
Matthew,
obviously, sorry, James.
Matthew, this is why we have a range on our target, because we don't know what the impact is going to be in terms of increase in terms of new members. So that's why we estimate 108 to 110. It may be more than 110 for the family glitch. We have an idea on our system who may qualify as of now. So that's why we're able to give you a range. All right. So that family glitch is going to be hugely benefit to Connecticut residents. And as Susan said, our system, once it was announced, we started working on our system immediately. So it's ready. It's been ready to go for a while now. We're just waiting for the final ruling. It's come out. So November 1st, it'll be in place.
And I see there's a question. Do you want me to just quickly cover the other topics, or does someone have a question they wanted to ask on the family glitch rule?
No, that was me, and please keep going. Thanks.
Okay, thank you. And just to touch on something, a case we talked about last month, Braidwood Management versus Becerra. And this is the case dealing with the preventative services mandate, which is obviously very, very important. So right after the September board meeting, the judge had a status conference and he set a briefing schedule for the parties. The next briefs are due October 24th, and the rest of the schedule goes into mid-January 2023. So we really won't know anything for several months. And the items that the parties are going to be briefing is the scope of relief, whether there might be injunctive relief, the standing of the plaintiffs other than Braidwood Management, and also any outstanding issues on the contraceptive mandate. There were other issues in the case other than the preventative services mandate. And then there's just one other item I just wanted to add just a little bit of information on. We've been talking about the plans and the type of coverage available. And we just wanted to note for everyone, and we're going to be messaging this in our open enrollment messaging about the value of our plans and the first dollar coverage that is available under them. As Ted mentioned, the plans all have coverage for preventative services with zero cost sharing right now, which is very, very important. But we also want to make sure that people know that many of our plans, including the standard silver plans, the standard bronze plans, the non-HSA bronze plans, and the standard gold plans, offer coverage for services that consumers really use often. And this coverage is provided before the deductible is met. So that means people don't have to worry about that big number that might scare them off that deductible. They can visit a PCP or a specialist. They can have mental health and substance abuse office visits. They can use lab services and access generic drugs and only have to pay a copay or a coinsurance amount, depending on the plan, without having to meet the planned deductible. And also to note, the standard silver plans have a separate, very low deductible for prescription drugs, those in the tiers other than the generic drugs. So we just want to make sure that consumers also understand, as we've been talking about their cost sharing and consumers' health costs, what is available to them under our plans. And I think that's an important message that maybe a lot of people don't quite understand. So thank you.
Thank you. I think you have a question from Commissioner Gifford.
I'll be very quick because I know our time is almost up. Susan, on that point, the no out-of-pocket cost for preventive care. A question came up recently with respect to contraception. We had a provider who was asking us about charging for certain contraceptive costs. And they say that people who are coming in to see them as an out-of-network provider are being asked to pay out-of-pocket costs, even if it's a preventive service that would otherwise be free under the ACA. So you don't have to answer now if it's a complicated question, but it would really be helpful to us to understand how the network relates to this no out-of-pocket costs under the ACA. I had always understood that it didn't matter in network or out of network, no out-of-pocket costs, but it would be helpful to have an expert respond to that.
Yes, we can look into that. I don't want to misspeak, so I want to double check on that. And I know in our plans, certainly in the standard plans, we require them all to have out-of-network coverage as well as in-network, but the cost sharing obviously can be different. But we'll check on that on preventative and contraception when we can get back to you.
Thank you.
So
Appreciate
thank
it.
you.
Mr.
Okay.
Chairman, given the time, I would dispense with any further comment from me.
Well, thank you all very much. I think this is an important time of year for the exchange, obviously, and very important to look at these issues thoroughly, which you have done for us. So, again, my thanks to everyone, including the directors and the management. Look forward to talking to you next month.
Mr. Chair, we need to make a motion to adjourn.
Yes, please. So, if I could have a motion to adjourn,
So
please.
moved, Ted.
Thank you, Ted. Second.
CC Wood, second.
Thank you, CC. Charlie Klippel, yes.
Thank you. Claudio Galtieri,
Yes.
Deidre Gifford,
Yes.
Grant Ritter,
Yes.
Steve Hernandez,
Yes.
Theodore Doolittle,
Aye.
CC Woods,
Yes, and great meeting.
Thomas McNeil,
Yes.
and Matthew Brackman.
Yes.
Thank you so much.
Thank you, everyone.
Bye-bye all.
Bye-bye. Thank you.
Thank you.